Here is your question. All right, so if you have read and understood, consider it as critical care scenario. Please tell me, how would you manage this patient now?
Yes, I would manage this patient according to the ACLS protocol, ma'am.
Okay.
Airway, breathing, circulation.
Yes.
So since this is a case of head injury, consider it is as an EDH, epidural hematoma.
Okay.
So
EDH is extra dural.
extradural hemorrhage.
Yes.
So I will shift the patient in ICU and I will monitor him. I'll monitor the intracranial pressure.
Yes. But before
And
that,
I would, if the patient is stable, I will shift him for CT brain.
yes.
And then I will proceed, ma'am, depending upon the CT and the patient's general condition.
General condition and vitals. Okay. This patient, when patient arrived, has had Glasgow Coma scale of 15, and then Glasgow Coma scale decreased to 8. Why? What might have happened?
This is a scenario of lucid interval, ma'am.
All right.
So initially,
Define lucid interval.
yes, lucid interval is nothing but initially the patient is performing well in his general status, followed by rapid deterioration in his consciousness, and the patient's general condition deteriorates rapidly, ma'am. This is called a lucid interval.
Yes, and it's the improvement which occurred was temporary.
Temporary, yes, ma'am.
Yes, and that has occurred because of increase in intracranial pressure.
Intracranial pressure, yes, ma'am.
Yes, all right. Can you please tell me if there are any ways you can measure intracranial pressure?
Yes, ma'am. There are several ways, ma'am. We can measure the intracranial pressure by probing the ventricles, which is more accurate, but it is technically difficult, and it has
classify them as invasive and non-invasive, and then
yes,
give me examples of each, please.
Yes, ma'am. Invasive methods are intraventricular intraventricular catheter, intraparenchymal probe, subarachnoid probe, epidural probe, and lumbar pressure, ma'am. These are all invasive. Non-invasive is tympanic membrane displacement and transcranial Doppler, ma'am. These are all non-invasive.
What is the normal intracranial pressure that you come across?
Normal is 7 to 15 millimeters of mercury, ma'am.
In supine position. How about
supine
in
position?
standing position? Would it remain the same?
No, in standing, it'll be minus 10, ma'am.
All right. Okay. Can you tell me if you would consider doing lumbar puncture in this particular patient?
No, ma'am, I wouldn't do, ma'am.
Why?
Because of raised intracranial pressure, if I do lumbar puncture, the patient might have coning or a herniation, ma'am.
Very good. Can you define the term Cushing triad?
Yes, ma'am. Cushing triad is defined occurs due to mixed vagal and sympathetic activity because of raised intracranial pressure, ma'am. So which leads to Cushing's triad. So that is hypertension or widened pulse pressure, bradycardia, and bradypnea or irregular respiration, ma'am.
Good. How would you differentiate Cushing triad from Cushing reflex? What is Cushing reflex in other terms?
Cushing's. Sorry, ma'am, I'll get back to it now.
All right. Okay. Can you tell me what do you understand by the Monro-Kelly hypothesis?
Yes, ma'am. Monro-Kelly hypothesis states that brain is a confined box, so which contains 80% of brain parenchyma, 10% of blood, and 10% of cerebrospinal fluid. So if there is any rise in one component, will result in decrease in the other two components, ma'am. So that maintains the mean arterial blood, CCP, cerebral perfusion pressure, ma'am. So if there is any alteration in the intracranial pressure, it results in
All right.
herniation.
Thank you. Yes, you said you'll transfer the patient in high dependency unit and you'll do the
Yes,
CT scan. All right. Can you tell me what is the criteria for doing the CT scan?
Yes, ma'am. It has two criteria, ma'am. One is major criteria and minor criteria. The major
Yes.
criteria, it includes open fracture or depressed fracture.
Yes.
GC is less than 15 after 2 hours post-admission. The signs of basilar fracture, base of skull fracture. So that is hemotympanum, autoria or rhinorrhea,
And
raccoon sign, and battle sign.
all right. So you've transferred the patient and now you've done the CT scan. Please help me to read this out. Just imagine this is the CT scan of this patient. How would you read it out, please?
It is a biconvex.
Yes, biconvex. Yes, and
biconvex hyperdense lesion in the left side, ma'am. So there is sorry, ma'am, in the right side, and there is a midline shift and and there is ventricular compression on the ventricles, ma'am.
Yes. All right. Good. All right. Okay. Now we'll begin from here. How would you manage the patient now? What other measures would you take?
The management depends. So I will try to
the
reduce.
ABC protocol. Yes.
Yes, ma'am.
Raise the head.
Yes, ma'am. Yes, ma'am. So my main consideration would be to maintain the cerebral venous flow. I would like to reduce the cerebral edema.
Yes.
And I would reduce the blood volume and CSF.
Yes.
And I would concentrate to reduce the metabolic rate for oxygen in the brain parenchyma.
Okay.
So these are the my main conditions, ma'am. So for reducing the cerebral venous flow, I would ensure that the patient is not having any restrictive compression collars. So instead, I will advise instead I would prefer the patient with tape and sandbag. Yes. And I would keep the patient head in a 30-degree position, ma'am. And if the patient is intubated, I will make sure the tube is not blocking the venous system.
Good. And
yes, sir.
You'll have fluid restriction in order to prevent cerebral edema.
Yes, ma'am.
Which diuretics would you suggest? Yes.
Yes, ma'am. My next important thing will be to control the cerebral edema. So I would give the patient mannitol, ma'am. So that is 0.5 to 1 gram per kg. It is an osmotic diuresis, followed by I'll give furosemide, ma'am. Furosemide. So that is 0.5 to 1 millimeter.
Yes. Mannitol you'll give over how long? Bell is going, but I want to make sure that you know the dose correct, because now you have mentioned the dose yourself. You could have avoided it by just telling that you'll give mannitol in order to prevent. But now that you have mentioned the dose, it should be correct.
Yes,
it should be correct. So please correct it. Tell me over how long, over how many minutes you'll give this dose.
10 minutes.
Bolus dose. Bolus over the period of 20 to 30 minutes. And
30 minutes, yes, ma'am.
0.25 to 1 gram per kg over 20 to 30 minutes. That depends.
20 minutes, yes, ma'am. 20% mannitol, yes, ma'am.
Yes. Right. And
Yes, ma'am.
yes, you'll also
So
take care of the, yes, what else?
next I will give furosemide, and then I will maintain the sodium level till 140 to 150 millimoles, ma'am.
Good. And yes,
And the next would be reducing the intracranial blood flow, ma'am. So that is I will ask the patient to hyperventilate, but not I will not ask the patient to I will
no, you
not make the
can't.
patient to
Patient is on ventilation, controlled
yes, ma'am.
ventilation.
Control ventilation, yes, ma'am. So if the patient if not, I would go for decompressive craniectomy, ma'am. Craniectomy.
Okay.
And to reduce the CSF volume, I would place an extra draining system for ventricles, ma'am. External
Yes.
draining system for ventricles. And
So,
to reduce
for
the
direct tapping of cerebrospinal fluid. Yes.
yes,
Very
ma'am.
good.
Yes, ma'am. And to reduce the metabolic oxygen rate, so I will make sure the patient is not hyperthermic, and the patient I will sedate the patient, and I will provide him with adequate analgesics, and after I will make sure the patient is under anti-epileptic measures, ma'am.
Very good. Okay. Right. I had to ask you one or two questions. Right. When would you consider intubating the patient?
Yes,
Time
ma'am.
has ended.
So
Your last question, please.
yes, yes, ma'am. I would if the patient is having laryngeal palsy, I will consider intubating the patient, and if the patient is throwing seizures, I will consider to intubate the patient, ma'am. And if
And
the GCS is less than 8, I
yeah,
will consider intubating the patient. And if the patient is having mandibular fracture, and if the airway is obstructed with hematoma or bleeding, I will intubate the patient, ma'am.
very good. And in case of elderly patients with pneumonia or
Yes, ma'am.
sepsis environment, when they cannot maintain their ventilations on their
Yes,
own.
ma'am.
Very good. Okay. Would you not, if you don't mind, just tell me what layers passes through when you are doing a borehole over the terion? If you can know the
Uh,
layers from outside to
yes,
inside.
yes, ma'am. Skin, yes. Connective tissue,
Yes.
aponeurosis, loose alveolar tissue, and periosteum, pericranium, ma'am.
Okay. And then until you'll reach the meninges then.
Meninges, yes, ma'am.
Okay. All right. Good. Thank you.
Thank you, ma'am.